another Sunday, waking on the ground.
Good morning. If you will begin to make your way to a seat. I always try to give a minute or two for folks to finish coffee, get in, gather, find a seat, settle in. All right, we're still saying hello. I'm going to give you just a couple seconds more. But if you would, come on in, settle in. So, I'm Rob Wagoner. I'm with Foundations. I'm going to start today as I have started each day this week. From the first moment I got up Monday morning at 4:30 and circumstances of my life changed with CNN and morning news. And so if you don't mind, I'm going to start this morning as I have started it each morning since Monday. My serenity is clearly in direct proportion to my level of acceptance of people, places, things, and circumstances over which I have no control. And so the news, the politics, the religion, this industry, reimbursement, regulators, my serenity is in direct proportion to my level of acceptance. And so for just a few moments, I am going to ask you to pause in a moment of silence for those this week who have lost their lives, for those that are still struggling as wounded and families surrounding them, and many others. So if you would join me in a moment of silence, and I will close us with the Serenity Prayer. Silence. Prayer. God, grant me the serenity to accept the things I cannot change, the courage to change the things I can, and the wisdom to know the difference. So this conference is a great moment and a time for me. It is a time for me to connect. I hope it is for you as well. Again, for those of you that are new to our conference, we work very hard to create not only high-quality clinical content, and you've got the A-team this morning, but high-quality clinical content and industry content, but also a great experience. And so I hope that you are taking advantage of the opportunities to network and connect. If you are still struggling to connect, that's what I'm here for. I'm the most highly paid juju reader out there. Come and find me and introduce yourself. I will read your juju. I will give you a really stupid ribbon, but it will give you a conversation piece. This is John Southworth, by the way, this end up. But it'll give you a conversation piece that allows you to connect with others, and I'll find out who you are, and then you tell me what you're attempting to do here, with whom you are attempting to connect, and I'll try to help you do that. So, in case you haven't seen it, this is our 50th national conference, you guys. 50 national conferences. Thank you. So, you guys make that happen, right? You guys make that happen. And so in celebrating our 50th National Conference, we're actually celebrating with a challenge to you. And between here and the exhibit hall, if you cut through the little passageway, you will pass Christy Crisman's Kindness Corner. And our challenge to you is 50 acts of kindness. You'll see a big wall that lists 50 acts of kindness that you can carry out even this week. And they are everything from picking up trash. And so I'm trying to get my name up on those 50 acts of kindness, picking up trash along the way to doing something locally here with Hurricane Irma and Harvey and other things. So please pass through and see those 50 acts of kindness. And I'll be honest with you, just reading them made me go, you know what? I can do that one. So go by and see Christy. She's adorable and excited and would love to get you engaged in the 50 acts of kindness. These 50 conferences, national conferences, it's our exhibitors and our sponsors who help make these conferences happen. And so I'm strongly encouraging you to spend some time, go down through the exhibit hall, see who is here, find out what they have to offer. And we challenge you with a game as you attend sessions and as you go to the booths, that it gives you an opportunity to participate in raffles to get you down there to meet the people who help make these conferences happen. It's ironic that there's a change on the agenda today that's the program offered by Avaya that's about better business solutions using technology, because your best solution to figuring it out is to download the app, the Foundations Events app. It is the most up-to-date. It lists for you changes that are happening, and there are changes in today's agenda. There are changes in the agenda tomorrow. So if you will download the Foundations Events app, it will tell you exactly, with GPS, it'll tell you where you are, and it'll also tell you what's coming up and changes. Their session will actually start at 1 p.m. today, whereas most sessions start at 1:30. Theirs will start at 1. They have 4 45-minute sessions up until 5, and you don't have to come to all of them. You can pick whichever ones you want to. But at 5, they will also have a reception following that event. Please check out the Thursday panels. There are some new panels, one in particular that's very powerful, including clinicians and law enforcement here in Palm Beach County. Tomorrow they will be talking about the opioid epidemic specific to here in Palm Beach County. So if you're local and you're from this area, these are folks that you will want to see and meet and participate in the conversation with them tomorrow. The registrations are up for the Dallas conference, November the 29th and the 30th, and the registrations are up for the San Diego conference that'll be in April 3rd through the 6th. So those things said, thank you for tolerating our daily announcements. Doug Tiemann is a dear friend and a dear man. I am so grateful for his example for me, for us in this industry. In the tumultuous world in our addiction treatment industry these days, I look for the beacons, I look for the lighthouses, and I look for the people around whom I can surround myself, connect with, and have accountability with. And that is an important part of ethics, is being transparent, open, and accountable. And Doug Tiemann is one of those people. I wouldn't hesitate to call, morning, noon, night, to reach out and say, hey, what do you think? And I'll be honest with you, he did that with me. And so the two of us then connected more and have kind of, I think it's fair to say, kind of helped push NATAP along a bit between the two of us and a smaller group of CEOs to say, you know what, we gotta get a little more active here and in the industry. So I'm very grateful for Doug. And so Dave Rotenberg, if you would, come on up here and you can continue that introduction. And thanks, you guys. Have a great day.
Appreciate it, brother. Okay, thank you, Rob. It's great to be here. I'm Dave Rotenberg, Chief Clinical Officer at Caron Treatment Centers. And it's such an honor and a privilege for me, having worked at Caron for 21 years and having gone through Caron as a patient 26 years ago, and then making it all the way back to this podium is unbelievable to me. To represent an organization that's known for 60 years of history, integrity, ethics, and as strong a measure of generosity and generosity of spirit as you can find in our industry. It's particularly sweet for me to stand alongside colleagues like Brad and Doug, who are your speakers this morning. Brad Sorti, after a meteoric rise through the clinical ranks of our Florida operation, is now the face of leadership, the vice president of our Florida continuum. It just keeps getting better under your watch, Brad, and we so appreciate having you. Doug Tiemann, as Rob mentioned, beacon of hope, barometer for our industry, friend, mentor, someone who always pushes the bar of ethics, integrity, outcomes, and is really a Hall of Fame member of our industry. I'd love to welcome you both and thank you for being our presenters this morning. Doug? Love you, boy.
Thanks so much, Dave. And Rob, thank you for that kind introduction as well. The feeling is certainly mutual. I think it was probably 1 year ago when we talked about what we needed to do as an industry, and we'll talk a little bit about that. I'm glad to be here to talk about this, but I'm also sad that we have to talk about this. Those of you that have heard me speak in the past know that I like to start with a farm story. So today's going to be no difference. And every one of the stories does have a meaning. Today's is probably a little bit more special because the topic is so serious. Maybe some little bit of lightheartedness to begin is maybe a nice place to start, because what I'm going to talk about is not very lighthearted. So I grew up in rural Missouri on a farm. And my father loved teaching us lessons by telling us stories. And I remember this one story. It was, we lived in a town of 294 people. I went to a one-room grade school with 14 kids, 5 of which were my brothers. By the way, I was in a class of 2, and I was in the top 2 in my class. You know, I have that on my resume. But we had a bank and a grocery store and a gas station. But farmers, you know, with land, oftentimes we needed legal advice. And we'd usually have to go to the county seat or another place further away to find a lawyer. So this story is about this young lawyer who decided, you know what, I'm going to come to the people. I'm going to set up a law firm, a law practice in a little town of Blackburn, Missouri. So he came into town, got a little office on Main Street next to the bank. And so one morning he's in there kind of getting everything ready, getting his desk set up, putting, you know, the nice plaques on his wall. Put a little bell on the door so that he would know if somebody came in. And sure enough, as he was getting stuff ready, he hears the bell ring. Guy comes in, so real quickly, he gets behind his desk, pulls up his phone, and starts talking a mile a minute. And he kind of waves to the guy out there, said, just a second, and he kind of ends by saying, as you can see, I'm really busy, but I'm going to look forward to helping you. So then he walks out to the guy and he says, as you can see, we're really packed here, really jam-packed, got a lot going on. What can I do to help you? I'll try to fit you in if I can, and if I can't, you know, call back in about a half an hour and talk to my assistant, and she'll try to find a time, probably next week or so, when I can meet with you. And the guy said, I'm from the phone company. I'm here to hook up your phone. My father told me that story because he said, you have to be careful in life as to perception of what might be versus actually someone who has the goods. And this, in some way, unfortunately, is a little bit of a commentary on our field about the perception of what might be versus who has the goods. Now, this story is funny, probably clever, but the question is, do you want to hire this guy as your lawyer? If we use that analogy with our field, probably not so funny. I will say this as I look at some of the marketing and billing tactics. I mean, when I first looked at them, I said, you know, that's pretty clever, really incredibly ingenious. But the question that the general public has out there is, do they want to buy those services from us? So, I have a number of goals for today. I'm going to highlight really the first and fourth goal. I want to talk about an ethical lens. I also want to talk about what we ultimately need to do about it. We're going to compare this illness to other chronic illnesses and what it should look like. And my colleague Brad Sorte is going to talk about that. Something that will likely happen is there's a real good possibility that we will irritate you. Some we're going to irritate because we don't talk about enough or come down hard enough. Some of you will probably irritate because maybe we don't go far enough. So if you find yourself irritated, you're probably in good company. We do have a couple of important goals that aren't stated here. Probably first and foremost is we want you to think about this. And number two, we want you to examine what you're doing, and we're going to try to give you some tools to be able to do that. How many of you were here last year when I talked about history? Any of you here? Okay, great. You remember I had a quiz in that? We're going to now do the quiz to see if you remember anything. No, just kidding. We're not going to do that. Doesn't remember if you were here last year. How many of you don't remember where you were a year ago? That's part of our problem too. But I do want to do kind of a quick review of a couple of important themes because I think it's always critical to take a look at how did we get here? How did we get here? I think wasn't the Laurel and Hardy show, geez, Ollie, what a fine mess you got us into. So how did we get into this mess? And we talked a lot about perception last year. And I talked about how our field over the years has not done a very good job at telling our story. And when we don't tell our story for us, others begin to tell it, and they haven't told it very well for us. We talked a lot last year about the importance of competition, which is good. In free enterprise capitalist system, competition raises the bar, helps the public. but we can't do it at the expense of cooperating and collaborating. That has really become the key to helping us establish standards. And when we don't do that very well, we have seen the stories in the New York Times, the Boston Globe, the Huffington Post, the Palm Beach Post, and the list goes on and on. So when they tell that story, what does the public see? The public sees an industry, a field that has no policing, no compassion, no results. And what do they see? They see the bottom line here. We're in this to make money. That's the perception that the public sees. How many of you saw this in the New York Times on Sunday? Christopher Smithers. Probably a lot of you know Christopher Smithers. I sat on a board with him and knew his dad, Brinkley Smithers, extremely well. A legend, a beacon in our field. This guy's a friend. By the way, you can't read this article very well on here. I just kind of made a copy of it to show you, but you might want to take a look at it. And look at the first couple of words there, how the opioid treatment, us, have fueled the epidemic. This is our friend. And if you go through that, he challenges the science, the protocol, our ethics. It's disturbing when our friends raise questions. That's where the perception is. Those of you that remember the history or from last year or know the history just because you've lived it, there is an outcome to this. The unfortunate outcome that we saw in the 1980s, which was kind of a golden era of addiction treatment in the United States, and in the 1990s we had a crash. A lot of you may remember the FBI raids, a lot of you remember the fraud, a lot of you remember some of the legal things that happened in the tarnish that they had on our field. This is bigger. It's bigger for a whole host of reasons. It's bigger because internet has helped it grow faster. We have a lot more capital invested today. The Mental Health Parity Act, the Affordable Care Act, the opioid epidemic, kind of a perfect storm. The industry is probably 5 times larger today than it was in 1990. So kind of remember that little song that we had when we were kids, when we talk about the second verse, same as the first, a whole lot louder and a whole lot worse. So if we don't get our act together, it could be a whole lot worse than what we saw in the 1990s. And a lot of you may remember, between 1990 and 1995, 1/2 of all the residential treatment beds in our country went away. Those are the kind of things that can happen. So, what do we need to do? First and foremost, we need to talk about healthcare. We are a sector of the healthcare industry, and we need to talk about it that way. We need to understand the laws and the ethics related to it. So those two words, it's kind of interesting. Probably till 3 or 4 years ago, in my first 30 years in the industry, I don't remember talking about legal and ethical hardly at all. 3 or 4 years ago, these became the hot topics. We started talking about it. Now every conference talks about what's ethical. And these two words have become kind of interchangeable when and there's a nice definition about each, and you're probably aware of that, but we typically put them together. Legal is real black and white. It's what the law says. The government comes up with laws. This is what it says. This is what you can do. This is what you can't do. And if you do it, you're going to get punished. Very simple. Ethics. What's the right thing to do? Everybody has different opinions on what's the right thing to do. If we look at the two as kind of being a tent, everything kind of falls under an ethical tent. Legal is some part of it because, by the way, it's unethical to break the law, so they got the legal section of that. Then we come over to the other section of what's the right thing to do. And we're going to talk about today in how do we determine what's the right thing to do. As I've gone around and started asking questions about this 3 years ago, and I would ask people what they thought was ethical. I came up with a very simple definition. What I do is ethical. What you do is unethical. We all have our own interpretation of that, and that's part of the problem of our field, is coming up with some commonality so that we can all be accountable and compliant. One of the things I've also learned is that it's important for us to understand what the law is. And as I talk to people around the industry, I've found kind of like 3 different categories of those that break the law. First are those that willfully break the law. You know, kind of looked at it and said, you know what, I'm not going to get caught. I've got great legal counsel and I can figure out how to not be punished. So that's a group out there. Probably not people in this room, but they're out there. The second group, and I was surprised at the number of folks I talked to about this, they kind of looked at like, insurance doesn't pay us what we need to get paid. We do good treatment, so it's okay to maybe bend the rules a little bit on billing because the end justifies the means. Someone got sober as a result of it. If they did the right thing to begin with, we wouldn't have to worry about this. So there are those. And then there's the third one, which I was also really surprised at, and probably most of us fall in this category of just not knowing the law. We see somebody else do it, a good, credible organization do it, and we say, you know what, it must be okay. It must be okay. It's sort of like I always talk about like driving 90 miles an hour on I-90 in North Dakota. You know, I mean, it's everyone else is driving 90. In fact, if you don't drive 90, you might get hurt because everybody else is driving 90. So, you know what? It's okay. It's okay to do it. The thing I want to tell you is that breaking the law, regardless of whether it's intentional or unintentional, ignorant or knowledgeable, is still breaking the law. And we have to appreciate that. There's a whole host of federal laws. I was amazed at the number of federal laws that actually impact the healthcare industry. And by the way, at the end of this, there is a resource guide. I'm not a lawyer. I don't want to talk about each of these specifically. However, at the end of this section, I'm going to give you a website that we put together where we go through all of the applicable laws that deal with our industry, a nice little summary. So even those of you like me who are not lawyers can look through it and get an idea of what those laws are all about. And it's important for us in leadership roles to know that they exist. NATAP last year came out, or actually this year came out with a list of what they called unethical marketing and billing practices. And again, here's a great example of us using sort of unethical and illegal almost interchangeably. These are also illegal. And again, in the resource guide that we're going to provide to you at the end, we actually go through and describe what these look like, because a lot of you are well aware there's a lot of machinations and iterations of each of these. It's important to understand and know what each one of those is. A group that has done a very good job at sort of outlining the playing field has been NADAC. So we're all well aware of unethical clinical behaviors. And this is a wonderful example of what we need to do around marketing and billing, what NADAC has done around clinical practices. They, over the years, have defined what is an appropriate patient-to-therapist relationship. Guidelines clear. You don't follow the rules, you lose your license. Very clear. There's other organizations like the Institute for Supply Management have talked about here's good ethics in doing business with other organizations. By the way, again, as part of our resource guide, we have NADAC and the Institute for Supply Management there for you to look through and take a look at all of that. One of the things that's really important for our field, and at the end, I'm going to talk about what do we need to do as an industry, because we need to have clear guidelines on what is ethical as it relates to marketing and billing, because having a lot of different groups out there trying to define what it is has become very, very cumbersome. And because there has been such a vacuum in our field, a vacuum from our associations in defining what it is, we have a lot of groups that have leapt into that. Again, we have some resources at the end for you to take a look at some of the ones that are out there, and they're doing it because nobody else is doing it, trying to do the right thing. Even institutions on their own today will talk about, here's what we do that's ethical. Groups have gone together and said, here's what we think is ethical, and we're all pledging to be ethical. And by the way, ethical pledges are good. I applaud that. I want to just, how many of you watch 48 Hours or Dateline? Those that don't raise your hand, you have a lot better social life than I do. My wife and I love watching those shows. Our kids call it adult porn for whatever reason. And the tip, for those that don't watch it, the typical thing is this. They show you a loving couple, and they talk to their friends about how well they get along. And it all looks great. One of them dies. And by the way, they typically in the first half of the show is they try to help you lead you to believe the person that didn't do it. By the way, the one that they always paint as the good guy at the beginning of the show, they end up being the one who actually did it at the end. And almost always it was the spouse that did it. That's the other thing we've learned after years of watching this. But here's what I wanted to share this, a very crude analogy. Every one of those couples took a pledge in front of God and their friends and their family. We will be faithful to one another. And they had good intentions to do that. But there's no policing of whether or not they would be, and ultimately in these cases on 48 Hours and Dateline, one of them ends up taking the life of the other one, not exactly part of the pledge. I share that with you because pledges are good. But if there isn't some policing and accountability, they are also relatively meaningless. And that's a big part of what we will need to talk about as well. How do we make that meaningful? So with that backdrop, it's important now for us to take a look at how does this compare to other chronic illnesses. And I want you to see, unfortunately, the sharp contrast about how we market, bill, treat addiction, substance use disorder, compared to another chronic illness. And so to take you through that journey, I'd like to introduce my colleague Brad Sorte, our Regional Vice President and Executive Director of Caron Renaissance and Caron Ocean Drive. Thanks, Doug.
Good morning, everyone. Again, thank you. Doug, thanks for the great lead-in, Dave as well, and Rob. And thanks, everybody, for being here this morning. And, you know, no conversation about best practices, about ethics, about really raising the bar in our industry would be complete without a conversation about what we do clinically. And Doug gave us a great framework around some of the ethical and legal implications, things that we need to be taking very seriously. Many of us already take it very seriously, but feel stifled and at times frustrated by the lack of cohesion, consistency, and ability to really affect change in our practices. But there's another component to this that I think is really important, and the topic of this section is how we talk about a chronic disease. Something happens when we talk about substance use disorders and we talk about addiction, where we talk about it as a chronic illness, but oftentimes our practices and some of our language around that chronic illness are inconsistent with the way that we would talk and conceptualize and treat just about every other chronic illness that we know of. And that sets the stage for several problems for us. One, it sets the stage for gaps in care for our clients. It also sets the stage for people who are potentially going to be engaging with us for our services to have some level of cognitive dissonance, because they may not necessarily have the understanding as to why what we say doesn't necessarily seem to match up with what we do and how we practice, but they feel that there is something inadequate in the way that we are approaching them. And so what I intend to do over the next 30 minutes or so here is talk a little bit about that, where we are, maybe why we're here, where we need to get to, and really the implications for you know, the current situation from the patient's perspective, and how we can best help them. So to do that, I'm going to figure out how to use the clicker. I want to take an example of another chronic illness. And I think that this is a great example of where we are today, that in many cases the treatment of addiction and substance use disorders today is where cancer treatment was 50 years ago. Very stigmatized, you know, referred to as the C word. Nobody wanted to talk about it. Very limited research at that point. There was different interventions, but the integration of all of those different fields had not yet come to fruition. And what you saw was that it was quite siloed, and that to a large degree, you got the treatment of the provider that you went to. That if you went to a surgeon, you got surgery. If you went to an oncologist, you got chemo. If you went to a radiologist, you got radiation treatment. But what you didn't necessarily get was a thorough process of initial evaluation, diagnosis, the ability to gather effective, useful, and evidence-based information to then make an informed decision about your care. And then ultimately, the individuals who are guiding your care and your treatment would determine a very individualized course of treatment, possibly drawing from all of those modalities to treat your specific manifestation of the disease. And this is a problem that we currently have in our industry, that we have patients and consumers who come to us and interface with us, and they get the treatment that we provide. One of the conversations that has been happening over the past few years, I believe we're beginning to move past it, but it still occurs, is the debate over whose way is the right way. That if you go to a 12-step-based program, you're going to get the 12 steps as the way to get sober, to get treatment, and to get into recovery. If you go to an MAT program, you're going to get MAT, the way to get into recovery, the way to get treatment. If you go to a spiritual-based program or a faith-based program, you're going to get that way. And the list goes on. And what you don't necessarily have is the dialogue that we really need to be having across the industry, which is that all of these practices that have a foundation in science and have shown efficacy for people need to be considered as part of the potential treatment regimen based on the individual that we are treating. We're talking about a dynamic and complex, multi-systemic chronic illness that manifests in people in different ways, who interface with the treatment continuum at vastly different points in the disease cycle. And to think that any one way of treating those individuals is the right way would be inconsistent with the way that we know and understand and conceptualize the treatment of chronic illnesses. So that's one thing that I think is a really important part to this. So I just wanted to kind of set the stage with that idea. And so I'm going to look at a couple of different iterations of where we are, where we should get to, and then the ideal situation, hopefully in the near future, that if we look at this, to a large degree, this is kind of the typical patient experience that we have right now. It looks cyclical. We have an acute onset of symptomology. Usually it's a hospital visit, it could be a legal consequence, it could be a family or a school or a financial consequence, but something happens where the symptomology creates such a degree of salience and disruption in the individual's life that something has to intervene and engage them with the health system. So I have an ER visit, for example, and subsequent to that, a quick referral, potentially into a detox program to detoxify the individual from the acute symptoms of withdrawal, and then referral into treatment. And I say insufficient treatment, not because a lot of the treatment that we have is insufficient, but because there are steps that are missing in the first part of this process where if we really believe that different people need vastly different approaches to treatment based on what their presenting problems are, very frequently, if that level of evaluation and due diligence is not done before the referral into treatment, that treatment may be insufficient for that person because it wasn't the type of care, it wasn't the type of services, it wasn't the type of approach that was going to be most effective for that person. And so if that's the case, and they end up in the incorrect program because the consumer doesn't necessarily have enough information to know what decisions to make because the healthcare professionals aren't educated enough to be able to do that, or as Doug mentioned, we have some of the more nefarious aspects that have been affecting our industry, that people are diverted or referred into programs for based on illegitimate means, we have a problem, because treatment won't be effective if that's not the right approach. We then have a reoccurrence of acute symptomology, and we're back to square one, and the cycle repeats itself. So if we were to just reconceptualize this a little bit differently, and just look at it through the lens of a chronic continuum, you know, we still have the acute onset of symptoms, but we have several intermediate steps that are extremely valuable for the patient in making an informed decision regarding their care and regarding what steps are going to be the correct steps for them. They're able to seek information. Concerned persons are able to get valid, reliable, scientific, genuine information from different sources regarding what's going on with me, what's going on with my loved one, and how to do an evaluation on what types of care that person needs. The next step is the doctor, or whoever that frontline medical professional is. If you go to your doctor, and we'll talk a little bit more about this on a later slide, but when you go to your doctor and you're presenting with any number of other symptoms of a chronic illness, diabetes, hypertension, early stage cardiovascular disease, if it's a physician, if it's a nurse practitioner, a physician's assistant, any one of them has had a diverse range of training and experience around the implications of that illness, the early manifestations of it, the implications for care, and what happens if it's unaddressed. We don't have that same level of sophistication and training on our frontline medical staff to be able to identify those issues when it comes to addiction. So already we have challenges with the information seeking on the consumer part. We have challenges on the evaluation and ultimately the next stage, the diagnosis from the physician or the frontline medical practitioner. And to a large degree, the diagnosis component in the cycle before, doesn't necessarily even really happen until maybe someone is already in the treatment program, which may not have necessarily been the right continuum of care for them. So if we're looking at this particular continuum, the point where the diagnosis is made and the treatment is then referred to, the idea being that it's more of an appropriate level of care, type of care, approach of care for that person's specific manifestation of their illness, and that ultimately one of the most important pieces is what happens after they leave. Again, this is a chronic illness. It's not an acute condition. So we need to be looking at our treatment models as one that looks at it through that lens. That the treatment of the acute symptomology of addiction and substance use disorders is very important, but if we really want to strive for the long-term benefit of our clients, it's what happens afterwards. How are we creating systems and structures of accountability, of lifestyle changes, medication management, ongoing care, and individualizing that component of treatment so that people are able to achieve outcomes over the long term? And that ultimately, if symptoms do reemerge, they have the tools available to make adjustments to that treatment program to get them back on track. The reduction in the frequency of acute symptomology and the increase in time between periods if it is to reoccur. So looking at it kind of specifically from a substance use standpoint, the first stage being whatever we want to kind of look at in terms of an intervention, whether it's a family intervention, a professional intervention, a legal consequence, any of the things that I'd mentioned before, detox, and then assessment. How are we thoroughly assessing our individual clients to determine what the next step might be, whether it is long-term residential treatment, whether it's an outpatient type of treatment, whether they have co-occurring issues, whether they have significant family issues. Are we looking at demographically? Are there certain types of programs that are going to be a better fit for that person based on stage of life, based on complications that they have within their family, based on personality structure, based on occupational responsibilities? And then looking at treatment being something that is phased, where the length of the acute phase of care is highly determined based on what that individual needs. And then finally, as we look at that final part, the maintenance piece, it's looking at how we individualize that so that it meets the specific needs of each individual person in all systems, from a real biopsychosocial, spiritual perspective. So I look at this as being kind of addiction treatment, substance use treatment 2.0, really taking a chronic approach to dealing with the illness. But there's a bold and italic point at the bottom there with question marks that I refer to early identification. And that's the part where I think we need to get to. That's addiction treatment, substance use disorder treatment 3.0. Any one of us, when we go to our annual physical, we get blood tests, we get urine to check our resting glucose, we get our vital signs checked, we get our blood pressure looked at, and we have conversations with our physician around, are there changes in any of these markers that are indicative of the early stages of potentially life-threatening and very complicated illnesses? We don't have conversations about that at the same level as it relates to our use of alcohol, as it relates to our use of illegal substances. If you go to a dermatologist appointment for your initial appointment and you fill out the medical questionnaire, they ask you if you smoke. If you go to an urgent care, they ask you if you smoke. If you go to any number of doctors, one of the major questions that's asked on there is it asks you about nicotine use. But you don't get the same level of thought and evaluation around the use of other substances. And so one of the things that I do think is a ray of hope with this is that while our frontline medical staff maybe has not been given enough training around the identification of substance use disorders and addiction issues long before somebody actually crosses the meridian to an acute phase of the illness, when they're still in maybe that harmful use phase, they are very good at identifying and consulting and articulating to their patients the implications of long-term nicotine use, the health consequences that will come from continuing to do it, and what the end game looks like. So there is a paradigm already in existence for our frontline medical staff in looking at a substance use that has long-term implications. And so I just put that out there because I think that there is a ray of hope that we have been able to really do a great job in educating doctors, and doctors being a frontline intervention in curtailing nicotine dependence in this country. But we need to begin to translate that and identify people earlier on. One more point about this that I think is really important as well is, as a society, we don't do a good job of being supportive, of reinforcing, and championing people who take a courageous look at their use of alcohol, let's say, and say, maybe I'm going down a path that's going to create problems later on. I think I'm going to cut back. I'm going to take a look at my alcohol use. I don't think I have a problem, but I'm going to look at it every once in a while to make sure that I'm not going down a path. There's fear associated with that. There's stigma associated with that. There's almost a perception that if I look at my alcohol use, if I look at my use of marijuana, if I look at how I've been on a prescription benzodiazepine for X number of years, then I'm kind of tacitly admitting that I'm an addict or an alcoholic, and then all of a sudden I can't go back from that. So I'm just going to play the ostrich and hide my head in the sand and hope that the cucumber doesn't become a pickle. And we need to really take a look at that and realize that we would never have the same attitude society-wise about people who say, my family's got a bad history of cardiovascular disease, so in my 30s I'm going to be really mindful of exercise, of diet, of nicotine use, because I don't want to put myself at a greater risk of developing a fatal, complicated, and painful life-threatening illness. So that's my vision in terms of where I want us to be, because I think that's going to be the most effective way to save lives and reduce the social costs of drug and alcohol abuse in our society is how are we able to head people off earlier? Not going to help everybody, because as much as we have conversations about diet and exercise, there's people who still have a hard time managing that, and they get cardiovascular disease, they get diabetes, but there's a lot that we can still do there, both from a medical perspective as well as from a society perspective. So the example that I want to juxtapose a little bit is the patient experience of someone who is dealing with addiction versus someone who is dealing with diabetes. I think they're two chronic illnesses that are a nice analogy for one another, because they tend to be operating in many systems. They tend to have life-threatening and potentially primary other illnesses that can be a consequence of having either addiction or diabetes. And they require a multi-systemic approach to medically manage them. So as you can see, complications with diabetes, cardiovascular disease, neuropathy, gangrene, macular degeneration, if it's not managed effectively. And if we look at addiction, similar sets of very life-threatening, very dangerous illnesses. So what happens first? The patient's symptoms manifest. We know the acute symptoms quite well for both of these disorders. The difference, again, going back to that early identification piece, it's highly likely that the diabetes patient who is now experiencing these acute symptoms, if they have been having some medical contact with their primary care doctor, has probably had some dialogue around the fact that they are moving down a path where they are eventually going to find themselves in the active phase of a chronic illness that is going to require lifelong management. Whereas the addiction patient as a whole may not have experienced that. But nevertheless, here they both are, both experiencing some of the telltale signs of the acute phase of the illness. So the first thing that they do is, let's say they go to their doctor. This is where the tree diverges significantly. So the patient with diabetes, they go to their physician. They have a medical professional who is well educated about the disease of diabetes, experienced in managing it, has diagnostic tools, which is a big portion of this, that makes it very easy to say that based on A, B, and C, you have this illness. Based on that, they are then able to say, these are the present implications for that. If you don't do these things, this is the future end game for this illness. And they are able to make effective referrals to facilities, to organizations, and providers, as well as interventions, medication, lifestyle, that are evidence-based, that are well-known and established, and that are easy for the consumer to corroborate through their own due diligence. Addiction's quite a different experience for the patient. You have our frontline medical staff with far less formal education about the identification, diagnosis, and treatment of addiction. You don't have a test or a series of tests that say, yep, you have this. A lot of it is dependent on collateral observation, family members, concerned people that may or may not be engaging with this caregiver. The individual may be dishonest about what's going on. Any private practice psychiatrist or physician or therapist who ever had a patient who comes to your office and talks about going on wild spending sprees and staying up late at night and having crazy affairs and doesn't really know why, and gosh, seems like someone who's got bipolar, but fails to mention that they're doing cocaine while that happens. So you have the physician and the frontline medical staff also disadvantaged from an information standpoint. And that's a real challenge, because then you have somebody who maybe gets misdiagnosed with something that is related to drug and alcohol use, but because they were obfuscating the presence of that behavior or that set of behaviors, they've now been given a wrong diagnosis of something that they may not actually have, but something that sends them down a rabbit hole for as many as years or perhaps forever, when it's really not what their primary problem is. And then the last big piece with this is that we don't have nearly as sophisticated a process for the frontline medical staff to refer our patients to good sources of information and good providers. That's not just on them. Again, that responsibility falls on us as an industry. And it goes back to Doug's last slide in really talking about the dearth of standards for outcomes, for best practices, for research collaborations and affiliations. So we have physicians who have a limited amount of training already who are even more limited by the fact that there is not a lot of sophistication, not a lot of consistency in what works, how it works, what works best, and where to go. So what happens next? Well, the patient, is disadvantaged from a diagnosis standpoint. Maybe they're diagnosed correctly, maybe they're not. Maybe they're looking at trying to evaluate on their own what's happening with them. So where do they go? Well, advertising now comes into the picture. Once again, we see a stark difference between what is acceptable, what is ethical, what is legal between general medical, diabetes medications, for example, and addiction treatment. So diabetes medication advertising, direct-to-consumer advertising is highly regulated. You see those commercials on TV where you have the happy couple running through the field and the sun is shining and the auctioneer speaking as quickly as he can in the background of the commercial about all the side effects, including death and dismemberment and all sorts of horrific things that can happen to you. Contrast that with an addiction treatment program commercial on TV that shows, sunny beach, people walking down, selling the promise of a life reunited without any kind of disclaimers, without any kind of necessity of validating the efficacy of that, and really no way for the consumer to know whether they can trust that. And then complicating things even more, we have some of the things that Doug talked about. We have practices that are illegal. Maybe we've been lacking enforcement on a lot of them, but the selling of patients to providers, the providing of incentives to induce people to go into programs, the selling of people who are looking for treatment to providers, and that goes back to the point where I talked about how treatment ends up failing people, because now people are getting referred to places not based on what necessarily is the right place because of a thorough evaluation by a physician and the due diligence that they have done and looking at the research, but they're going to where they go because that's where they ended up, not because it's necessarily where they needed to be, and that's a problem. And the analogy that I also like to use with this, one more piece. So the patient then does their own due diligence, and they go to the internet. So obviously there have been some changes in the past 2 weeks that Google has made in eliminating certain keywords from Google AdWords. But we use this because it was important to see the juxtaposition between what would happen if I typed in addiction treatment near me in a search engine and I typed in diabetes. Diabetes, there's one ad for a diabetes medication and an ad for the Juvenile Diabetes Foundation. And then you have WebMD, American Diabetes Association, Medline, I think, is the other one up there, talking about information for the consumer. And on the addiction treatment side, for Addiction Near Me, it's all ads, many of which are probably not programs that are near me, and many of which might not actually be programs at all. So if we're thinking about this from the lens of the consumer, they go to the doctor, they may or may not be forthcoming with the doctor may not have complete information to help make a diagnosis that they're really not that well trained to make at that point. The consumer then goes to try to seek information, they're met with this. They're scared. This is one of the worst experiences of their life because they or a loved one is dealing with addiction. They're seeing and hearing the stories of tens of thousands of people dying in their own community, you know, the way I always try to conceptualize our responsibility as practitioners, our consumers are very naive in terms of knowing what works and what doesn't work. We have a great deal of responsibility to guide them and be their advocate. And it's somewhat of a facile analogy, but I'll use it anyway. I try to remember it through the lens of what it's like for me to get my car fixed. I can open the hood. I can see there's an engine there. If there's something wrong with it, I can put washer fluid in. I can change a tire. I probably couldn't change my own oil. But I take my car in. Somebody tells me, hey, this is what's wrong with your car. And I say, okay. I've got no way to validate it, and I've done that dozens of times in my life, and I'm not under duress when I'm doing it. But for the vast majority of the people who are picking up the phone or clicking on Google, who are reaching out for help, this is as much of a black box to them as that engine is under the hood of my car. And at the same time that they are desperate, they are so vulnerable to exploitation by being sold a dream, a promise that requires no scrutiny on the part of our industry in validating whether or not that's true. And that costs people lives. And that's very serious. So again, looking at the two experiences here, and we wonder why at times people look at what we do, you know, as pseudoscientific or don't take us very seriously. It's because of things like this. It's because of our inability to really take the same level of scrutiny and scientific evaluation to what we do and do it consistently and really look at this as a chronic illness. So, you know, what does the treatment look like? Well, you know, detox inpatient for the person with addiction. You know, we don't necessarily, you know whether or not they got to the program that was the right program for them. The person with diabetes is getting some sort of individualized regimen that includes, but not limited to, things like diet, things like exercise, things like nicotine cessation. Maybe they're on medication, maybe they're not. But before they start that acute treatment, a thorough evaluation is done saying, well, you know, you're pre-diabetic right now. You probably don't need to start on medication. Why don't you lose 30 pounds? Why don't you stop smoking? Why don't we send you to a registered dietitian? You get on an eating plan that'll kind of change the way that you're interfacing with food and your diet. And maybe you'll see that your symptomology will go down. You can prolong the period of time or even prevent the onset of the chronic part of the illness. Again, largely we miss on that component as it relates to what we do. The management part. There is a huge body of research and evidence and research that is dedicated to evaluating what of these interventions for diabetes work. Being able to find that information is much easier. And unfortunately, what we have for addiction is that we don't have standards, we don't have consistency, and we don't have enough research to be able to really show these are the things that we need to have. These are the things that need to happen in months 6 through 24 after somebody leaves a treatment program to ensure that they have the greatest chance of having a reduction in the frequency of symptoms and an increase in the amplitude, or excuse me, increase in the period between when those symptoms actually occur. It goes back to what Doug talked about on his last slide. Limited to no consistency in these areas. Insurance also plays an important role in this. And so, you know, we struggle to get reimbursement as an industry for probably parts of treatment that are most important. So what happens to somebody, like I said before, in months 6 through 24 in terms of some sort of monitoring program, case management, ongoing therapy, urinalysis to have some accountability, devices where people can be giving a breathalyzer. Very limited access for that at the point in time when people are probably at most risk of returning to the acute phase of their illness. So again, we also need to look at the fact that the more that we can prove that we have a paradigm that works to treat things over the long term, the more that we can then demonstrate that it's effective and that it is valuable for both our patients who are paying out of pocket and for our payers who would be paying for people who are covered by insurance to finance that for them so that they can remain in recovery. And then the relapse part is also dramatically different. So if someone has a relapse of their symptoms of diabetes, it's looked at through the lens of, okay, a reoccurrence of the active phase, we need to adjust their medication, we need to look at their lifestyle, do they need to change a few more things? But it's non-judgmental. And unfortunately, we are still very stuck in a judgmental approach to what happens when people do not remain in remission for their entire life from drug and alcohol use and disorders. And that's a problem. That makes it difficult for people to seek help. That marginalizes people who get help, have a great reduction in their symptoms, but aren't perfect, and then feel like they kind of fall into a category of people who, aren't necessarily accepted as someone who was successful, but still feel guilty about the fact that maybe they have a problem and they're not, quote, normal anymore. How do we reach those people? How do we help them understand that there's a way to re-engage the treatment continuum at the point that's most appropriate for them so that they can get back to their recovery? And then treatment failed. Well, treatment fails when people get the wrong treatment. And that goes back to the point that we were talking about in the very beginning there, that the evaluation of what is the right treatment for somebody is extraordinarily important early on, and then that same evaluation regarding what type of treatment is needed for someone for essentially the rest of their lives to help them remain in remission is extremely important to reduce this idea that treatment failed. The right treatment, because it's backed by lots of evidence, is effective when applied correctly and taken through the lens of a patient-centric approach. So how do we transition to this model? I think we need to really think about what our message is. Are we a healthcare sector? Do we deliver healthcare services, or are we, selling amenities? What do we talk about in terms of our messaging? What do we talk about in terms of what is important to our patients? How do we talk about the services that we deliver? Talking about our staff qualifications, talking about evidence-based practices. What are our academic affiliations? I think this is another really important part. If you look at some of the best hospitals in the country, most of the best hospitals in the country, there are these robust, dynamic collaborations between them and medical schools within our universities that have a synergistic effect of both training the next generation of medical practitioners on how to identify, treat, and effectively intervene on a whole range of illnesses, as well as providing the research horsepower to advance the discourse, to advance the science, to evaluate if what we're doing is working or if what we are doing needs to change. We are so limited in that when it comes to the academic affiliations with addiction medicine. There are so few of those that, and the example that I oftentimes like to give is that if anyone in this room needed cancer treatment or a loved one needed cancer treatment, very quickly probably everyone in this room could rattle off Dana-Farber, MD Anderson, Mayo Clinic, Sloan Kettering, Johns Hopkins as 5 of the top 10, maybe 5 of the top 7. And know that based on the research affiliations that those places have with Harvard, University of Texas, Johns Hopkins University, brings a horsepower and a research component that you know that you're getting the best in class, and you know that the methods are being evaluated. I think you'd be hard-pressed to kind of go through the same process and rattling off the top 5 addiction treatment programs in the country. And I think you'd certainly have a hard time in identifying which ones have the most robust academic affiliations and are really involved in advancing the science. This is something that we need to become far more involved with. We can't be siloed out of the rest of healthcare in not doing this. We also need proper measurements, quality indicators, and outcomes. And we need to consistently agree on what they are. We need to understand what we are measuring, what indicates success, and we need to agree upon that, and we need to have that validated so that the consumer can then begin to look at our body of evidence and our practice and say, I can understand this. I can see from point A to point B why this works, why I need to do that. Addiction is a complex, chronic, and treatable disease. It's multisystemic. It affects people on all systems: family systems, biological systems, emotional systems, psychological systems. And the treatment of people with addiction and substance use disorders requires intervention that is dynamic on all of those. The last point that I kind of want to leave you with is this idea that largely healthcare has moved to an outcome-based model, except for us. If you look at other chronic illnesses, very little of the measurement of success is, did somebody get into remission for the rest of their life? We look at it through the lens of lifelong remission is the North Star. And if we can help someone with diabetes, hypertension, asthma, cancer get into lifelong remission, that's great. But there are going to be a percentage of people that can't do that or aren't able to do that, or it's just elusive for them. How are we creating treatment solutions for the entire population so that we can look at the people that maybe that is elusive for as having a successful outcome because they've had significant decreases in the level of dysfunction in their life, significant elevations in the level of happiness, fulfillment, consistency, engagement throughout all those systems, and begin to look at the fact that, that can be a successful outcome as well if we are looking at intervening on those people periodically through that maintenance component so that when they do have regression or symptoms of their acute condition reemerge, we are nimble and quick to get them back on track and keep them functioning and moving in a positive direction. So, with that, I'm going to turn it back over to Doug, who is going to talk about how we're going to get there.
So what Brad describes is utopia. It's where we need to get to. So the question is, can we get there? Let me just say, for the benefit of the patients and the families that we serve, God, I hope so. And more importantly, we need to get there. So I want to talk about some of the efforts that are being undertaken to help us get there. I look for a day in which we don't talk about the illegality or unethicalness. It's very negative. Look forward to when we don't have to do that and instead focus on what Brad talked about. These are the things that we should be talking about and where we need to get to. When we look at the other illnesses, there are all kinds of rankings and ratings that help the consumer and help the insurers. CMS, Star Ratings, U.S. News and World Report. They're centers of excellence for diseases. That's where we need to get to, and we can. One of the things that when we talk about ethics that just kind of struck me, and I wanted to put this in here for that, when's the last time you went to a doctor or a hospital and they said, oh, by the way, I'm not unethical. I'm not illegal. But yet, in our field, because the last couple of years, we feel it important to tell people that. When we go to other forms of healthcare, we expect integrity, ethics, playing by the rules. That needs to be the commonality of this. We shouldn't have to talk about it. So I want to just share with you a handful of efforts, and I'm going to encourage you to learn about them. I'm going to encourage you to be part of them. With each of these, there is a great resource guide that we're going to make available to you so that you can learn more about them. I'm sure a lot of you may have questions about them, and I think the information that's provided at the end will help you with that. One of the things I also wanted to say, because we're going to go right up to 10 o'clock, is that there is no kind of official Q&A for today, but if you have some things that you would like to talk to Brad and me about, we will be here afterwards, so please come up and chat with us, and I hope you'll find that the resource guide we provide at the end will be helpful as well. Rob mentioned NATAP. I'll be candid. I was even chairman of NATAP for a number of years, involved with the board for a number of years. This association was asleep at the wheels. We all can take responsibility for that. It's associations that are so critical for determining the ethical standards. Again, going back to the conversation earlier, legal is law, black and white. But if we have this wide array of what each and every one of us thinks might be moral, might be right, we need somebody, some group, to determine what is indeed ethical so it's not so gray. NADAC has done a great job, as I mentioned, on the counselor-patient relationship. NATAP is now saying, primarily because of some efforts that both Rob Wagner and I took with NATAP a year ago, to say we've got to be the place where that happens. We need to have some very clear guidelines on what is ethical for marketing, what's ethical for billing. It needs to be crystal clear. So it's one of the things that the organization is now doing. And at the resource guide, we're going to give at the end all kinds of information that you will, as it relates to what those guidelines are going to look like. But the most important part is clear guidelines so that everybody understands what they are. You may agree, you may not agree, but they're going to be clear. Then we have to be able to police them. We have to make sure that there's some consequences if you don't follow the guidelines. You're going to have a list so it's real clear to the consumer and to the payer. This is the list that playing by the rules, an important differentiator. We've talked about whether or not we'll be a self-regulating organization or not. That's to be determined, but the important part is guidelines, training, list, policing, which is a great protection for those that we serve. There's some other organizations that we've highlighted in the resource guide we're going to provide. If you're not a treatment center but are recovery residents, as we know, a lot of work's been done by NAR and FAR. So great guidelines. We need to be part of our associations that are doing this. A lot of groups that are not associations, because of the vacuum, as I mentioned earlier, have jumped in and tried to do some things. They're trying to do the right thing. But it's our associations that can provide the necessary policing that we ultimately have to have. How many of you know Gary Mendel? Okay, couple of you. Gary Mendel started an organization called Shatterproof, lost his son to heroin addiction and decided, my son's life needs to have a purpose. So he started this organization called Shatterproof and doing a lot of awareness about it. But one of the things that he's now undertaken is to try to help, now that he's creating awareness for people to get help, very frustrated because people don't know, as Brad mentioned, where to go for good help. So he kind of looked at 4 different groups, and he's starting with the top one first, and actually has a session this month in Washington, D.C., being moderated by the Pew Charitable Trust, saying the first place to go is let's get the payers together. So because of the networking he has available to him, he has the top 7 payers of the United States all coming together for a meeting this month, being moderated by Pew Charitable Trust. Those 7 are responsible for about 75% of the total third-party reimbursement in the United States. So he said, if we can get the payers to come together and say, here's the expected criteria for a substance use provider to be paid, that's a good start. He's got these other groups that are listed here that he's going to also be working with. Eventually, he's going to come to us, groups like NATAP, and say, what do you think should be the standards? He's going to then get some consumer groups together, and finally, the last is the government, which has to do with licensing and regulation. So a year-long project, but a guy with the means, the wherewithal, and the personal drive and commitment. So be aware of what Shatterproof is doing. Going to make a difference. And it's starting with payers, which is going to affect all of us. Had some great conversation with Penny Mills at ASAM, and Brad talked about the importance of the physician. We think the physician is critically important in this, and the American Society of Addiction Medicine is probably the place it needs to start with. Penny even shared with me stories about how organizations on their website will say, we use ASAM placement criteria. And she says, and they don't. So some of the things that they're going to be working with, and she didn't want me to go into too much detail on this, but she said, stay tuned for 2018, some press releases on what they're going to be doing with CARF, because they really want to become the provider of standards, very clear criteria, and certification on the various levels of care that they provide. And again, it's going to be a great way for us to have consistent standards and something our field has never had, centers of excellence. Treatment centers on their own can just say, we're a center of excellence for young adults, or we're a center of excellence for opiates, and just kind of put it out there. So one of the things that the American Society of Addiction Medicine is going to do is, what does it take to be a center of excellence? What's the staff-to-patient ratio? What are the credentials? What are the kind of research do you have to do? What kind of academic affiliations do you have to have? What kind of physicians do you need to have on board? We need to talk about this as healthcare, and it's great to see that the American Society of Addiction Medicine is doing something about it. Then there's this whole other array, which is the legal piece of it. Because of the attention that the media has brought to this, legal groups are now looking at it. There have been a number of congressmen from districts that have been particularly hard hit by both the opiate epidemic as well as places where there have been substantial amount of abuses, taking a look at, should we introduce federal legislation to deal with our industry? The regulatory agencies are beginning to take a much sharper eye and look at us. And one of the things I would just mention, and again, it's in the information that we have in the resource guide, I had always thought, and maybe some of you had thought, if you don't take Medicare and Medicaid, maybe some of the federal rules around billing don't apply to you. Well, because of the Affordable Care Act, and if you take insurance from any of the exchanges, guess what? Even if you didn't know it, it could have an impact on you. So understanding the laws, because the regulatory agencies are starting to look at us. Former Congressman Mary Bono is working with the Federal Trade Commission and the Blue Cross Blue Shield Association to take a look at appropriate marketing and the way we represent ourselves. So FTC is starting to take a look at how we do this. The states that have been particularly impacted have done their own, and Florida is probably the shining star in that with what's happened here. Again, in the resource guide, we have an overview of laws in Florida, California, New York. Just this week, the Attorney General of Massachusetts has said they're going to begin looking at fraud, particularly for patients that are being sort of exported out of Massachusetts to others. A lot of you in this community know how Dave Ehrenberg has been involved with activities in Palm Beach County. Task forces popping up all over the place to deal with this. I'd encourage you to get involved with them. All of these are important because it gets to be the policing part of it. I go back to my I-90 analogy. Once there are speed traps there and you start getting stopped and you start having to pay fines, you start taking a whole lot more serious look at how fast can I drive. So the policing of this is a good thing for all of us. The insurance industries, I've talked to the Blues, talked to Cigna, and all of them are extremely concerned about this. And as I mentioned, they're meeting with Gary Mendel this month to talk about what are the criteria. So if we don't get our act together and do this appropriately, they'll get their act together for us. And when we saw what happened between 1990 and 2000, when they take the reins, it's not necessarily good for the patients that we collectively serve. Google, we're all aware of what happened with that. And if you didn't read the Alcohol and Drug Abuse Weekly article, we have that in here as a link as well at the end for you to take a look at. But the thing that disturbs me and saddens me is when they talk about there's only been 2 industries previously that they've done what they've done to us. And one is the same-day paycheck loan business, and the other one is locksmith. They consider both of those criminal fields. What a sad commentary that our field is put in that same category as others that Google considers criminal or industries that are dominated by criminals. What a horrible, horrible commentary. Read the article. And there's probably more things to come on all of these areas. And maybe the great public protector is the media. We're well aware of the articles. And the articles don't paint us in a very good light, and they don't tell our story very well. Now, again, we understand that the whole goal of selling newspapers and media is sensationalism, so they take the bad and make it really look worse. We need to stop those stories. We need to not give them this to talk about. We need to show the advances that we're making. So how do we restore trust? This is kind of the summary and what I'm asking all of you to think about, examine, and how you can get involved with this. NATAP. For those of us that are addiction treatment providers, get involved, understand what NATAP is doing. As I said, at the end of this, a great resource on all the things that NATAP is doing. Get accredited at the highest level you can. Take when the ASAM criteria comes out next year and what you need to be certified at the various levels, take that seriously. Be part of the healthcare conversation. I'm going to talk about the third bullet just a little bit more because it's so incredibly important. Get involved with outcome studies. Be authentic about it. And for those of you that are involved with the NATAP's outcome study program, get involved with those. Be part of that conversation. I talk about your facility, as Brad said, talk about the healthcare part of your facility. We're a healthcare industry. And if you take nothing else away from this, you can forget everything if you want, but I want to highlight the first 2 bullets on this. You've got to have a compliance officer. We just got one at Caron a little over a year ago, and I was amazed when you have somebody who knows the law, understands the ethics within the associations at the lens that you begin to look at what everything you do. We're do-gooders. All of us in this room are do-gooders. We try to do good every day. But sometimes our best intentions may color outside the line. So get a compliance officer. You'll be amazed at the integrity they can bring. And our compliance officer at Caron, at every one of our quarterly board meetings, I actually exit the room at the end of the board meeting, and she has an opportunity for them to ask questions about anything that I or senior management might be doing that might be questionable. It's a whole nother lens. I would encourage you to have a compliance officer, because having someone who knows all of these laws, and when you pull the resource guide up and you see how many there are, it's important to have somebody who does have that kind of legal background. I think it's important for all of us to make sure we have something for our patients to let them know that we care about them. We want them to get well. So in whatever version you might want to have it, you need to have some type of Bill of Rights that we care about you and we want you to get well. So that we don't have to say, by the way, I'm not illegal or unethical. Our organization is one that's committed to your recovery. When we look at the 1990s, kind of talked about last year, like who survived? Had nothing to do with whether you were for-profit or not-for-profit. One thing was really seminal: those that cared about helping people get well. That's what I'd really ask all of you to keep your focus on. If your focus is on your patient, regardless of small or large, for profit, not for profit, you take care of patients and can demonstrate that you do that, you will survive, but more importantly, you'll be there to help the future generations of the growing number of people who suffer from substance use disorder. And I want to leave you with a great sort of analogy. I don't know how many of you know Dr. Robert Dupont, first director of NIDA, runs a think tank in Washington, D.C. called the Institute for Behavioral Health. I'd encourage you to take a look at that as well. But he talks about chronic illness. He talks about the HIV epidemic and how we eventually defeated that to a degree, put it into, really have made a real impact on that. And he talks about the 90-90-90. And the goal of that was 90% of the people who are HIV infected would get tested. 90% of the people who came back positive would go and get treatment. And 90% of the people who got treatment, the disease would go in remission. So he's talked about that. And he said, by the way, Magic Johnson coming out and making it every person's disease certainly had a positive impact as well. So he said if that same analogy for us is to go back to Brad's showing how this looks from a medical health perspective, we need 90% of the people who suffer from substance use disorder to get diagnosed by their doctor. And SBIRT is certainly a good way to get started with that. We need 90% of the people get diagnosed to get some kind of treatment, the right treatment, not just some kind of treatment, but the right treatment. And we need 90% of those to have that disease go into remission. North Star would be for the rest of their life. But if it gets controlled and manageable and they have improved quality of life, we've done a pretty good job with that. And it's possible that maybe we'll get our own Magic Johnson as well. When we think about when our field did well, Betty Ford was one of the greatest spokespeople we've ever had. We need another Betty Ford. We need a Magic Johnson. And we also need to take a look at this as a healthcare illness that it is. If you go to, wanted to show where the resource guide is. If you go to Caron.org/moments of change, we will have on there a wide variety of the resources that I talked about. They're all hyperlinks. You can go directly to them to get it. There's also another one that is not extremely long, but it's fairly long, where we go through all of the laws that I mentioned so that you could take a look at what a Stark law is. What is the legislation that just passed in Florida? So it's a nice sort of syllabus of all of that. So I'd encourage you to take a look at that. I want to just conclude by saying I really appreciate your attention, appreciate all of you being here, third day of a conference. I know that always gets a little more difficult, but you are part of the solution. We need you to now embrace the solution, work with our associations, help us determine what those standards and outcomes can be. And as I said, the most important beneficiary of this are the people we serve. We need people to have an opportunity to get recovery for life. So thanks so much for being here.
Every time you give someone your trust, they throw it back. They throw it back. Another Sunday, waking on the ground.